Hello, wonderful staff of the Northwest Kidney Center, particularly at the flagship unit in Kent. Today we're going to explore the exciting and changing world of vaccination against pneumonia. Why are we talking about this? Because the Northwest Kidney Center is actively administering a relatively new pneumococcal vaccine, and I thought it would be good to understand why we are doing it, particularly if you are questioned about it by a patient. This talk has three objectives. First, understand the pathogenicity of Streptococcus pneumoniae. Why is it so dangerous for humans? Second, recognize the two types of vaccines that are commercially available against strep pneumo. And finally, review the effectiveness or the efficacy of the available pneumococcal vaccines. So let's begin by discussing some features of Streptococcus pneumoniae. Streptococcus pneumoniae is also known as pneumococcus. It is a gram-positive spherical bacteria. It's an anaerobic member of the genus Streptococcus. It's usually found in pairs, so-called diplococci and gram stain, although it can be found in chains. And it was first recognized as a major cause of pneumonia in humans in the late 19th century. So all of us have strep pneumo inside of our respiratory tract. So it's in our sinuses, in our mouth, in our nasal cavity, and it just lives there, cohabitates with all of our bacteria, doesn't make us sick for the most part. But under the right circumstances, say in a very young patient or a very old patient or in someone with a weaker immune system, such as a dialysis patient, the bacteria can become pathogenic and spread to other locations and cause disease. And specifically, we call this invasive pneumococcal diseases. And these include things like bronchitis and acute sinusitis, ear infections called otitis media. You can get eye infections like conjunctivitis. It can go to the brain and cause meningitis. It can go to the bone and cause osteomyelitis or septic arthritis. It can affect the heart valves called endocarditis, etc. It spreads typically by person-to-person contact via respiratory droplets, although you can also auto-inoculate yourself. So again, you've got this bacteria in your mouth and in your nose. And for example, if you aspirate, some secretions from your mouth or your nose into your lungs, you can essentially give yourself pneumonia. Strep pneumo is the main cause of pneumonia and meningitis in children and in the elderly, in addition to all the other invasive pneumococcal disease. But that's the number one cause of pneumonia and meningitis. Importantly, there are more than 100 different serotypes of pneumococcus, and these types differ in virulence, in prevalence, and the extent of drug resistance. Strep pneumo is surrounded by a thick polysaccharide capsule, and hence it is known as an encapsulated organism. The capsule acts as a virulence factor for the organism. Also, it serves as a target for the currently available highly effective multivalent vaccines. The history of the discovery of pneumococcus is very interesting. In 1881, it was first isolated simultaneously and independently by the U.S. Army physician George Sternberg and the French chemist Louis Pasteur. The organism was first named pneumococcus because of its role in causing pneumonia. But then in 1920, it was renamed Diplococcus pneumoniae because of its characteristic appearance in gram-stained sputum. Di is a Greek word for two, and again, this organism typically occurs in pairs. In 1974, it was renamed Streptococcus pneumoniae because it is very similar to other streptococcal organisms. Interestingly, strep pneumo played an important role in demonstrating that genetic material consists of something called DNA, which had not yet been discovered. In 1928, a British bacteriologist by the name of Frederick Griffith did an interesting experiment that you can see up top here. He first injected a lethal strain of strep pneumo into some mice, and the mice died. In the second part of the experiment, he injected a benign strain of strep pneumo into the mice, and the mice lived. Then, in the third part of the experiment, he injected a killed lethal bacteria. So basically, took the lethal bacteria from first experiment and he killed it with heat and he injected it into the mice, and not surprisingly, the mice lived. But then, in the most interesting part of the experiment, he co-injected both the benign as well as the killed lethal bacteria into the mice, and they died. So the presence of the killed lethal bacteria somehow transferred its pathogenicity, its lethality, to the benign strain of strep pneumo. So there was some factor which was transferred between the two strains, and it was originally thought to represent a protein. Then in 1994, some researchers, Oswald Avery, Colin McLeod, Michael and McCarty, demonstrated that the transforming growth factor in Griffith's experiment was not a protein, as was widely believed at the time, but DNA. And Avery's work marked the birth of the molecular era of genetics. Okay, back to strep pneumo. So strep pneumo, as I said, is a part of the normal upper respiratory tract flora. And as with many natural flora, it can become pathogenic under the right conditions, typically when the immune system of the host is suppressed. After strep pneumo colonizes the air sacs of the lungs, then the body responds by stimulating essentially an inflammatory response, causing plasma blood, white blood cells to fill the air sacs or alveoli, and this condition is called pneumonia. Symptoms of pneumonia include fever, chills, cough, trouble breathing, chest pain, confusion, among other symptoms. Pneumococcus is also the #1 cause of meningitis, which is an infection of the tissue covering the brain and the spinal cord. Patients present with fever, headache, confusion, fear of light, or the pain associated with looking at light, as well as a stiff neck. Pneumococcus can also cause sepsis, which is an overwhelming response to an infection, leads to tissue damage, organ failure, and is a common cause of death. And patients who have sepsis oftentimes have low blood pressure, fast heart rate, confusion, shortness of breath, fever, chills, etc. This graph shows the rates of invasive pneumococcal disease by age, and you can see that it's highest for kids, from birth up to the age of 4, and then above the age of 50, it really starts to increase. So basically, invasive pneumococcal disease is predominantly an infection of the very young and older adults. There's growing resistance of strep pneumo to antibiotics. If they are resistant to penicillin, we call them penicillin-resistant pneumococci. In 2015, about 30% of the strains were resistant to one or more antibiotics. And that resistance is basically conferred by a genetic mutation which alters something called the penicillin binding protein structure, so resulting in essentially decreased affinity for penicillin and other beta-lactam antibiotics. Particularly with the rise of resistant organisms, a better way to manage pneumococcal infections is to prevent them using vaccines. So pneumococcal vaccines are vaccines against the bacterium Strep pneumoniae. They can be used to prevent cases of pneumonia, meningitis, sepsis, and other forms of invasive pneumococcal disease. There are two main types of pneumococcal vaccines: conjugate vaccines and polysaccharide vaccines. They're given by injection either into the muscle or just under the skin. First developed in the 1980s, and they're so important that they're on the World Health Organization's list of essential medicines. So as I just mentioned, there are two types of pneumococcal vaccines that are commercially available. One is the pneumococcal polysaccharide vaccine, or the PPSV, and the other one is pneumococcal conjugate vaccine, or PCV. The active components of both of these vaccines are capsular polysaccharides. So basically, sugar molecules in the capsule of the bacterium from pneumococcal serotypes that commonly cause invasive disease. So the PPSV vaccine, or the pneumococcal polysaccharide vaccines, are composed of partially purified pneumococcal capsular polysaccharides. There's only one commercially available preparation of that, is the PPSV23, also known as Pneumovax, and it contains 23 pneumococcal polysaccharides from the 23 serotypes that were the most common cause of pneumococcal disease in adults in the 1980s. So I've listed out the numbers here: 1, 2, 3, 4, 5, 6B, 7F, etc., etc. Immunogenicity is induced primarily through stimulation of B cells with the release of an antibody called IgM. And this does not involve T cells, so it just stimulates the B cells. There are some limitations of the PPSV vaccine. First of all, the immune response is less robust than the response provoked by the conjugated vaccines. It's ineffective in children less than 2 years of age, and non-response is common among older adults. Immunity is not lifelong, so individuals need to be revaccinated at the age of 65 if their initial vaccination was at the age of 60 or younger. And it does not induce something called mucosal immunity. That is immunity where your mucosa is, basically inside the nose, the sinuses, the mouth. So it doesn't affect carrier rates. So if you have mucosal immunity, a host can get rid of the strep pneumo along its mucosa, again in the nose and the mouth. And if it gets rid of that type of bacteria, then it's not going to pass it on to other people, and that can lead to herd immunity. It can also protect against upper and lower respiratory tract infections. The second type of pneumococcal vaccine is the pneumococcal conjugate vaccine, or PCV. It consists of, again, capsular polysaccharides, just like with the PPSV vaccine. But in this case, the capsular polysaccharides are covalently bound or conjugated to something called the diphtheria toxoid. Diphtheria toxoid is a highly immunogenic but non-toxic protein. Diphtheria, just for background, is a serious bacterial infection that usually affects the mucous membranes of the nose and throat. It's rare these days because of vaccination, and diphtheria produces a serious toxin that has been chemically modified to form something called a toxoid. So it's no longer toxic, but it can still be used to stimulate an immune response. So what the vaccine manufacturers did was they combined the pneumococcal capsular polysaccharides to this diphtheria toxoid, resulting in a much more significant immune response. Basically, it recruits not only the B cells, but also helper T cells, which allow for the production of non-IgM immunoglobulins and the production of memory B cells. And that results in mucosal immunity. So basically, if you eradicate strep pneumo from your mucosa, your mouth, your nose, your sinuses, then you don't get colonization of the strep pneumo, and this can lead to lifelong immunity after several exposures. So PCV vaccines were originally developed for pediatric use, and so earlier formulations included serotypes that cause most disease in children, but more recent formulations have selected serotypes that commonly cause disease in adults. There are several available PCV formulations, and the numbers indicate the number of pneumococcal capsule types included in the vaccine. So for example, you have PCV10, which includes 10 of the polysaccharides, PCV13, which has 13, there's a PCV15, and more recently now we have a PCV20, so the 20-valent PCV or Prevnar 20, PCV20, this is what we're administering at the Kidney Center. So the PCV vaccines, again, can lead to mucosal immunity, which is really good. You can eradicate certain strains from your mucosa so that you don't spread them to other people. What that in turn, though, has done is led to the emergence of replacement strains. So just as an example, the serotypes present in PCV7 and PCV13 have nearly disappeared from the pediatric and adult populations, which is great. But as these serotypes disappear, we've seen the emergence of new pneumococcal serotypes, again, so-called replacement strains. The vaccines are very effective. This graph shows the cases of invasive pneumococcal disease per 100,000 population over the past 20 years following the introduction of PCV7 and PCV13. Essentially, vaccination has reduced the number of cases over the last 20 years by about 50%. Let's now talk about vaccine recommendations. In other words, who should receive the pneumococcal vaccines? Pneumococcal vaccination is recommended for all adults 65 years of age and above, or adults aged 19 to 64 years with essentially predisposing chronic medical conditions like renal failure or any sort of immunocompromising condition, HIV, malignancy, uh, again, kidney disease, which is associated with reduced immune function. In 2018, about 43% of invasive pneumococcal disease occurred in those above the age of 65, and another 48% occurred in adults less than 65 years of age with predisposing conditions that I mentioned above. Pneumococcal vaccination is not recommended for healthy adults less than 65 years of age. And although the risk of pneumococcal disease starts to increase at the age of 50, basically analyses have suggested that initiating vaccination at that age would not be cost effective. And so generally we don't start to vaccinate people until they reach the age of 65. If you have received a previous pneumococcal vaccine, say one of the older pneumococcal vaccines, when should you be revaccinated? Well, the approach to revaccination really depends on the specific vaccine that a patient previously received. For example, if they received the PPSV23, the pneumococcal polysaccharide vaccine 23 only, then you should receive the PCV20 at least a year after receiving the PPSV23. On the other hand, let's say you receive the PCV13 only. Well, then experts recommend that you receive the PPSV23 vaccine at least 1 year later. If that's not available, then a single dose of the PCV20 can be administered instead. If someone previously received the PPSV23, if they're above the age of 65, it's recommended that they receive a second dose. But if they get the PCV20, they don't need the second dose of the PPSV23. And finally, if they've received both the PCV13 and the PPSV23, no further vaccination is needed. If someone has received the PCV20 alone, say like our dialysis patients, or they get the PCV20 plus the PPSV23, or the PCV15 in series with the PPSV23, no revaccination is necessary. If someone received the older formulation like the PCV13 and PPSV23, then again, revaccination with a PPSV23 depends on age. Say they're above the age of 65. And again, the standard recommendation for the PPSV23 is to have it redosed at the age of 65 years and then every 5 to 10 years. But if they get the PCV20, which is what we're administering at the kidney center, they don't need to be revaccinated. The pneumococcal vaccines are well tolerated. Injection site reactions occur in about 20% of patients who receive either the PPSV23 or the PCV vaccine, so it's similar for both. You can have systemic symptoms like fever, chills, headache, fatigue, joint pains, etc. Fever occurs in less than 5% of patients. The only real contraindications to receiving pneumococcal vaccine is if you've had a severe allergic response to either a pneumococcal vaccine in the past or to any of its components like the diphtheria toxoid. So how effective are these vaccines? Both the 23-valent pneumococcal polysaccharide vaccine and the pneumococcal conjugate vaccines are immunogenic in adults, meaning that they induce an immune response. Numerous studies have compared the responses of the two vaccine types, but they have failed to demonstrate consistent differences in immunogenicity between them. So how do we assess immunogenicity? Well, one way is to measure antibody levels. PPSV vaccine generates IgG antibodies that remain elevated for 5 to 10 years, although the vaccine efficacy wanes over time. PCV antibodies level remains elevated for at least 2 years, but longer range studies have not been reported for this type of vaccine. In frail and elderly subjects, there does not appear to be a significant difference in immunogenicity between the two vaccine types, but in immunocompromised patients, limited data suggests that the PCV may be more immunogenic compared to the PPSV23. The efficacy of these vaccines has been assessed by several randomized controlled trials that evaluate for differences in disease incidence over time. PPSV23 vaccine has been looked at by a meta-analysis of 18 randomized controlled trials evaluating over 64,000 subjects and reported a reduction of 72% of invasive pneumococcal disease and 54% in pneumococcal pneumonia. Conjugate vaccines have been looked at in a large randomized controlled trial called CAPITA, published in New England Journal of Medicine in 2015 of over 84,000 Dutch adults, 65 years and above, who received either the PCV13 or placebo, and they found a 75% reduction in invasive pneumococcal disease and a 45% reduction in pneumococcal pneumonia. Now, serotypes that cause pneumococcal disease continue to change as new conjugate vaccines are added to immunization programs. This is due to a reduction in PCV serotyped nasopharyngeal colonization rates of pneumococcus. So if you get rid of certain serotypes because of the vaccine, well then replacement strains take their place. So one of the reasons that we like the PCV20 and PPSV23 is that they just cover more serotypes than the other vaccines. So if someone is high risk, anyone who's immunocompromised, for example, then generally we recommend both the PPSV23 and the PCV20 vaccines. Okay, let's summarize what we've learned today. Streptococcus pneumoniae is the #1 cause of bacterial pneumonia in humans. It resides in healthy carriers in the respiratory tract, sinuses, and nasal cavity. But when someone has a weakened immune system, such as elderly, young children, or dialysis patients, the bacteria can become pathogenic and spread to other locations to cause invasive pneumococcal disease. Pneumococcal vaccines are effective in preventing cases of pneumonia, meningitis, and sepsis. We have 2 types of pneumococcal vaccines available: conjugate vaccines and polysaccharide vaccines. Both are given as an injection either into the muscle or just under the skin. The active components of both vaccines, what stimulates the immune system to make antibodies, are the capsular polysaccharides from the pneumococcal serotypes that commonly cause invasive disease. The combination of the pneumococcal capsular polysaccharides to the diphtheria toxoid provokes a more robust immune response, has the potential to lead to lifelong immunity as well as mucosal eradication from susceptible individuals. Vaccines are effective against invasive pneumococcal disease and non-bacteremic pneumonia. And the Northwest Kidney Center is now administering the 20-valent PCV, also called Prevnar 20. I hope you all were paying attention because this month's quiz is exceptionally difficult. Question number 1, what is the most common cause of bacterial pneumonia in the United States? That's right, strep pneumoniae. Question number 2, what 2 types of vaccines are currently available against strep pneumoniae? That's right. Conjugate vaccines and polysaccharide vaccines. Question number 3. Which pneumococcal vaccines need to be administered only once? That's correct. Conjugate vaccines. Again, these vaccines contain polysaccharides, capsular polysaccharides that have been conjugated or covalently bound to the tetanus toxoid, very immunogenic, thought to produce a longer, more sustained immune response than the polysaccharide vaccines. What are the main side effects of the vaccines? Correct. Inflammation and pain at the site of injection occurs in about 20% of patients who receive the vaccine. Same incidence with the PPSV23 as well as the PCV vaccines. Final question. How often should the pneumococcal vaccines be administered? Depends on the type of vaccine. If they receive the PPSV23, it's every 5 to 10 years. If they receive the PCV20, again, what we're administering at the kidney center, no revaccination is recommended. This concludes the February 2023 in-service for the Northwest Kidney Center. Thank you so much for your attention, and thank you again for your excellent care of a population of patients that really need you. This is Andy Brokenbrough signing out until next month. Have a great day.